Symptoms and signs. So what are the symptoms? So we talked about it a bit, but what are the symptoms of congestive heart failure? We talked about the main one, which is dyspnea. Okay, especially if we talk about the left heart, that's dyspnea, 100%. So dyspnea is the main symptom. That's what the patient will describe. But what else? If it's a severe congestive heart failure, what are the problems they will have? Exactly, fatigue. They could be already disoriented when the perfusion of the brain is decreased. If I'm having a serious hypotension, I can be disoriented. So these are all, let's say, depends how the patient will describe this as a symptom, but yeah, they can say they feel dizzy and whatever. So there's going to be dyspnea, they can be dizzy, okay? And okay, but yes, exactly. And now it depends if it is, with the symptoms and stuff, sometimes they overlap. Right? Like edema, they can describe they're having edema. If they will start to fail with the right heart, they can feel that they're having edema, although you as a doctor doesn't have to see it. But if it's get more severe, then it's a sign. Okay, so some of them overlap, but it's those are those tiny differences which don't matter at the end. But yeah, symptoms that he describes, so dyspnea, that's 100%. And with the signs, what will be the signs? And we talked about it. So as a clinician, you can see it or hear it or whatever. So definitely if there is a lung edema, I can hear it. Because if I'll put a stethoscope, I can hear rails and whatever. Okay? Then what else? If the right heart fails, then I'm going to have JVD. You will put the patient in a semi-supine position or whatever. Or semi-vertical position as you want. And you will see that the veins are enlarged. You will see if it's longer or if it's serious, you will definitely see, or you will palpate bigger liver, okay? And of course, if the patient's going to stand up, he's going to have swollen legs, both legs. Right? They can be pretty thick. In the morning, it's better. Later during the day, it's getting worse. Yeah, of course. But over here, we're coming to the dyspnea, so I'm coming back to the symptoms, and that's so typical, and that's a question of many international tests. And that is one specific thing that they will mention in specific time that they have problems. And this is what should ring the bell for you. Help. This could be congestive heart failure. Yes, when they lay down. So why do they have problems? What problems? Breathing. So the dyspnea worsens. So what they do? They get up. And this is called orthopnea. So for them, it's better to breathe when they're verticalized, when they're standing up. And guess when this worsens typically? What time? At night. So typically, when you lay down in a bed, suddenly you're having a dyspnea. And basically, you can call it paroxysmal nocturnal dyspnea because they lay down. And typically what they say, hey doc, I'm not feeling so well in the bed, but, every time I stand up and I open the window, the air, it's so nice. It's so much helps me to breathe. And we know it's not the air. It's because they stand it up, okay? So they decrease the congestion in the lungs. They moved it to the legs, okay? So typically, what is the position they sleep in?
Half sitting.
Yeah, half sitting, exactly. So they have more, they put pillows behind them, and that's the way how they sleep. You call it orthopnea. Okay, so remember, orthopnea and paroxysmal nocturnal dyspnea. That's a typical sign where, bumps into your head that it could be congestive heart failure. Okay? So remember that. Orthopnea, crucial. Also, there is one thing you could hear. If it's a dilated or systolic dysfunction, typically what you will hear on auscultation is a S3 gallop. Remember that, S3 gallop. That's crucial. So S3 gallop, orthopnea, when they ask you this question, that's a congestive heart failure, congestive left heart failure. Okay?
What is S3 gallop?
Normally you hear two sounds. This is a third one, okay? Yeah. Play it on YouTube or wherever. Put S3 gallop, you'll hear it. So, those are the signs and symptoms, but what about the clinical things or diagnostics? What is the crucial method in diagnosing and telling you a difference between a systolic and diastolic dysfunction? In other words, if the heart is dilated or if there is a hypertrophy. And it's a crucial method for cardiology, totally. And this method, you need it for monitoring the outcome of the therapy of the congestive heart failure. What? It's ultrasound, so echocardiography. So echo is a crucial. That's the one which tells you the volumes, if there is a restriction or if there is a dilation. That's the only accurate way how to do that, okay? By the way, there could be a sign thanks to auscultations, but it's, of course, once you have an echo next to you, always use the echo. It's better. Nowadays, it's sort of a waste of time to do auscultation if I can do an echo immediately. But if you want to have an echo, is there a way how you could guess in a way? Or you could say this could be dilation in a way. You know what? Typically, if there is a normal size of the heart, you should hear the loudest, let's say, contraction, or you should hear the apex in the fifth intercostal space. If it moves to the sixth one, it is very likely dilation because the heart got dilated and the apex moved a bit lower and lateral, okay? So it could be, so auscultation could be, but of course the most important diagnostics is echo. And this will 100% tell you if there is a dilation or what ejection fraction I'm actually having. So if there is a preserved or reduced ejection fraction. There's a molecule in the blood that also can tell you that there is, or very likely you can exclude with this. If it's not there, you can exclude, not 100%, but you can very likely exclude heart failure. Which molecule floats in the blood that is increased, that it's very likely. No, that would be what? It could be, but troponin is when you have MI. So yeah, it could be there, and then you can assume this could lead to dilation, but it's BNP, guys. Brain natriuretic peptide, and that's released every time the ventricles are overstretched. So remember BNP, but watch out, during lifetime it increases, so you have to sort of approximate this to age, okay? But increased BNP over average means fail, or in other words, if there is not increased BNP, very likely it's not heart failure, okay?
So BNP indicates that the ventricles are stretched?
Yeah, that are dilated. They're like overstretched. Yeah? Yeah, BNP. Increased BNP. It's released from the ventricles, the BNP. ANP is from the atriums, BNP is from the ventricle. Although it means brain-derived natriuretic peptide because it was first described in brain. Later we found out it's released by the left ventricle as well, and right as well.
Is this the opposite activity of NP?
No. It works the same way. So it's natriuretic. But don't forget the MPs natriuretic peptides, they're also very important signaling molecules in cell-to-cell talk, okay? For example, if you have mutation of the natriuretic receptor, you have a failure of growth, and etc. So there are many, many similar molecules, okay?
Sorry, you said atrial is
ANP, atrial natriuretic peptide, or factor. So you're getting rid of sodium and water, okay? So this was the diagnostics. Remember orthopnea. And what about acute and chronic congestive heart failure? So this is like timing. Acute means like hours or day. So if it's acute heart failure compared to chronic heart failure. By the way, all the cases then later are chronic. And basically, with the acute, you should think of a fast decompensation. So what could cause there are many examples, but what could cause an acute heart failure? Well, could, if you get an infusion or something, fine, but let's talk about more. Yes, pulmonary embolism, exactly, yes. So pulmonary embolism, definitely. What about left ventricle or right, both? What is so common, and it's connected with troponins and CKMBs and What's that? Myoglobin. Well, if these are increased in the blood, that is what? It's MI, of course. So MI, if it's a serious MI, if there is a big chunk of meat necrotic of the muscle, then of course you're going to have a acute failure. And is there something without any like serious, let's say, damage to the muscle, but it could be really serious?
Exercise. I could be like very strong.
Well, it depends, but okay, if it's an old heart, then okay, with exercise I could do it as well, but then you will trigger what? Either you will trigger MI or arrhythmia, okay? So remember arrhythmia, like serious ventricular tachycardia will turn into acute heart failure, okay? So watch out, arrhythmia. And what I also want to stress in arrhythmias, and this is what you should understand. It could be also an older heart which is chronically slowly failing. So sort of compensated, but it's failing. In these hearts, one thing is very important, because if I'm having a healthy heart and I'm not exercising or whatever, I don't need atriums, like the kick at the end. So it's not so important. Of course, if I start to exercise, it's getting more and more important, the function of the atriums, okay? But imagine the other scenario. So now my heart is failing, my left ventricle is failing. So in this case, the function of the atriums becomes crucial, because now, like, it helps me in 30%. It helps me to fill the heart at the end. So the function of the atriums becomes more and more important if the heart is failing. So what can happen suddenly to the atriums that I'm losing the 30% of the help? Something that is not serious normally so much. And I'm talking about arrhythmia, the most common arrhythmia, which is, well, more common is AFIB, okay? So AFib is the most common one. And in this case, I will lose the 30%. So suddenly, if the left heart starts to fail, thanks to that, I can have a flush pulmonary edema. So serious dyspnea with fatal consequence, okay? So what you're going to do, if now suddenly the situation worsens because the AFib appears. So AFib. So guess what you're going to do? And this is basically what you always look for if the failure is the cause of a arrhythmia, okay? Because in this way you can also very fast normalize it, because if you do a cardio conversion, if you do a conversion and you bring back the normal beat and you stop the AFib, you will improve the situation immediately, okay? And this accounts for all the other arrhythmias. So it depends what is the trigger, okay? So AFib, for example. Okay, so acute, it happens suddenly, and there are many causes, of course. In chronic, there are many causes as well, but in this case, this is the classical scenario, the chronic heart failure that you are imagining with a systolic and diastolic dysfunction in a way. This is what you see, what patients come there, they have a systolic and diastolic dysfunction, different severity, but still they're compensated in a way, okay? It's totally a different way how you approach them in treatment, but we'll talk about it in a sec. So, that was acute and chronic. And now remodeling and cardiomyopathy. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.